Welcome, everyone. I'm excited to welcome you to this episode of the Sunflower Podcast, a podcast exploring all aspects of children's palliative care around the world. Sunflower Podcast is bringing curiosity, humor, and reflection to the world of palliative care. We're exploring the joys and challenges of working in this incredible field, including topics related to education, advocacy, self-care, service provision, and leadership from around the world. My name is Rachel Neufeld, and I'm thrilled to be here as a guest host for this podcast. I'm a pediatric palliative care nurse practitioner in Vancouver, Canada, working for Canuck Place Children's Hospice. Hello, Rebecca. Can you please introduce yourself and what your role is here, where you work, how long you worked here? Give us a little bit of an intro to you.
Sure. I'm Rebecca Woodward. I'm an RN here at Canuck Place Children's Hospice, where I have been a bedside nurse for 16-ish years. And recently, in the last couple of years, I've begun doing CRN work, which is clinical response nursing. And that's helping mentor bedside nurses, disseminate education along with the team, leadership, and also supporting in the community through our enhanced community care program.
Great. I wonder if you might let us know kind of what drew you to pediatric palliative care, because you've been in it for quite a number of years now. So what drew you to this in the first place?
Long ago, at the start of my nursing journey, I realized that pediatrics is where I wanted to be. So I, started my role as a nurse in pediatric acute care. And I soon realized that a hospital setting is not where I needed to be because the turnover in the hospital was just so fast that you didn't really have time to build the relationships and get to know these kids and their families the way that I really wanted to get to know them. And so I was drawn to the focus of family-centered care that comes with pediatric palliative care, and that's what drew me to Canuck Place.
Awesome. I would love to hear about some of the maybe rose and thorns of your job in pediatric palliative care. So maybe what are some of the hard pieces? What are some of the really good pieces, good and the bad, of doing pediatric palliative care?
All right. So let's, start with some of the thorns. I think pediatric palliative care in itself, when people think about what that means, in itself is a thorn, because the realization that children do die, it's a hard one, and that itself, I think, could be the thorn of pediatric palliative care. Another thorn that I can think of in working in this role is being on a journey with oncology families in particular, and watching, the focus being around acute treatment and looking for cure. And those families, sometimes, the oncology team will give them the information that there is no longer cure and there is no longer treatment options. And that's when we step in and we become, primaries or closer to these families. And just watching that transition from treatment focused to comfort focused can be a thorn as well as a rose. But in the beginning, that thorn could be seen as loss of hope. That's when we really step in beside these families. And I think the rose comes from, us redefining what hope is to this family. And then that also encompasses what the other rose in my thoughts are the relationship building and being able to become, the primaries for these families and really, build trust with them and help support them towards the end of their child's trajectory here, but also helping them to, live in the moment and live for now and live really well.
Yeah, thanks. I think a lot of our families also hesitate to share the news of that treatment no longer curative. How do we share this with our child? How do we share this with the rest of our family? We're worried that this child will lose their spark. They're going to lose their hope, things like that. So I see a lot of our role is helping families to redefine that hope, that it's not the perspective of there's nothing more we can do. It's these are the things we can do that will still benefit your child. But it can definitely see the hard part of that transition and maybe some of the resistance to it but also a lot of the really good work that can happen as we support families through that. I would love to pick your nursing brain a little bit around how we might manage some of the common symptoms that we see in pediatric palliative care, and specifically from a nursing lens of maybe how we assess and how we approach managing certain symptoms. So I wonder if you could give us a little bit of your perspective on how we might manage pain with our kids here.
All right, let's do that. Well, I just wanted to start by saying that Canuck Place in recent years now, we've become Child Kind certified, and we really pride ourselves on being able to assess pain and to intervene to eliminate suffering in these kids the best that we can. And if that means just a distraction box for, to play with some toys while we're getting a little needle poke, or being able to assess the effectiveness of opioids, or if not increasing if needed. We really pride ourselves in being able to do that. So I think the first thing that we're really good at is assessment, and using different tools, pain tools, FACES scales, numeric scales, depending on the age of the child or cognitive abilities, and just to determine like an overall baseline for what we're seeing. So we might not like jump in right away into some treatments, but just to see, what they're showing us. And we can start with things like repositioning them, or stopping their enteral feeds, or distraction. Some of our kids actually, they get really upset and show us that they're having pain just because they've got we got the wrong show on kind of thing. So we change the channel, and that could help some of our kids.
Can you tell me a little bit more about what you meant by a distraction box? Can you go into that a little bit more and what that means?
Yeah, so we have these distraction boxes that we would use if we anticipate that a child might become uncomfortable with the procedure that we might be doing, or become anxious. And so in these boxes, there's different tools we could use. For teens, for example, we have like mindfulness cards. For other kids, we have these like tactile stimulation type balls, and things that they can touch, or things that light up, and they're really quite distracting and fun. So sometimes you're off, like you'll have a nurse or a counselor, sitting with the child, and they're playing with these distraction toys, and the child's so focused on that they don't half the time realize that they're having a procedure done. So that's great, and that was amazing addition to our boxes of tools here.
I love that.
Yeah.
So once you've done some really thorough assessment of the pain, what would be some of your next steps?
So with Child Kind came what we call the 3 Ps, and we really want to make sure that we're addressing those. And those 3 Ps would be physical needs, pharmacological, and psychological needs of the child. And so things we look at would be, does the child need to be comforted? Are they anxious and that's escalating their pain? Do they need pharmacological interventions, medications, and such? Or like I said, for physical, repositioning them, changing their environment, changing the bed that they're laying on, like the mattress that they're laying on, getting them in an air bed, things like that. Even like splinting or non-splinting of contractures, that type of picture.
Yeah, I can imagine things like specific toys that are comforting, maybe a warm blanket, maybe things like cuddles, TLC. Those all would be in like that physical capacity that isn't necessarily just medications.
Oh, for sure. And our team, we really do, fight for the cuddles here, and the warm blanket. It's like a fridge almost, but it's the opposite of a fridge. The little heater, that thing's always stocked with blankets, because a lot of our kids really do love that, and especially with things like abdominal pain or back pain, like just to grab a warm blanket, and put it on their tummy and give them a little cuddle. Sometimes that can be enough.
Do we have other therapies that we might be able to draw on in terms of providing other physical and or psychological supports for these kids in their comfort? Are there other therapists, other allied health, other people that you might ask to be involved?
Yeah, within our team here, actually at the house, we have a recreation therapist. 3 of them actually on the team, and they provide outings and like fun activities, distraction type things to do while in-house. We also have a music therapist, which can be really soothing for some of our kids that have like some neuroirritability and they're just like needing to be soothed and also distracted with feeling different vibrations from the instruments and things like that. And we have got like vibration mats that we can use here as well. And then we also have play therapy with our counseling team. So the younger kids can go and do a play therapy session with a member of the team in the sand tray room, as well as sometimes our older crew will link up with one of our counselors and talk about, what's going on for them. And a lot of times like it's that total pain piece that we see. It's not always necessarily physical pain, but also psychological pain that these families and children are going through, and we need to address all those aspects.
Yeah, thanks. I think that highlights, even some of the situations we've encountered recently at work too, where the family is clearly having a lot of total pain. Can you tell me a little bit more about what that actually means? And why do we say total pain? Like, what are the things that you're assessing when you're considering that someone or a family is in total pain?
When I think of total pain, I think of just overall, it's overall pain. It's being overwhelmed basically with life and what is being given to you in this moment. There's physical pain and psychological pain. Their supports are falling apart. Maybe friends have distanced themselves. A loss of their hope. They're just feeling hopeless overall, and it goes to show that treating someone with medication for a physical symptom is not necessarily going to treat them for their pain.
Yeah. And I think about the PEST model that we use when I think about total pain. So, like you said, the physical, the emotional, the spiritual, the social, like they all can affect how a child's comfort is managed, and that it can often be many, many layers of treatments, and treatments aren't necessarily all just medication.
For sure, Rachel. And I think that's, it goes to show why our team, we work so well together and so closely together with like our prescribers and our nurses and our counseling team, our rec team. We just try to address all of those needs that are encompassed in total pain.
I'm curious about your perspective on some other symptoms that are pretty common in pediatric palliative care. So I wonder if we could maybe talk a little bit about dyspnea, knowing that dyspnea is quite a difficult symptom to manage at times. So tell me a little bit about what your perspective of what is dyspnea and how do you maybe assess it and take next steps to manage it?
When I think of dyspnea, I think of somebody's, perspective of their feeling of being short of breath. And we assess it in children that are verbal as well as, they're able to tell us, I am short of breath or I can't breathe, as well as nonverbal children who will show us panic facial expressions. We assess for things like grimacing, arching, nose to the air type thing, like looking for more air, just overall air hungry. So we would start there. And then there's some interventions that we can go into before we jump to pharmacological is, things like, okay, well, let's get some of these blankets off of you. Maybe like your clothing are too restricted. We can start you by using a fan, because sometimes just even the feeling of air, like cool air going across the face is helpful. We open windows and allow for fresh air to come into the room. A lot of times the dyspnea is also accompanied with anxiety too, like that is an awful feeling to have, and creates a lot of anxiety, and even just having like the people and things around them that provide comfort to them in those moments can be really helpful.
Yeah, and I can imagine the one other piece too that I'm thinking about is positioning, and each kid might have specific positioning requirements too. Some kids actually do better on their side, laying flat. Some kids will do better sitting up. I guess it depends on the cause, maybe the underlying reason for dyspnea. And so if we've tried some of these other things, we've repositioned them, we've turned a fan on, we've opened a window, we're not quite getting there, what are some of the pharmacological approaches that you might consider for dyspnea?
I think one of the gold standards that we reach for is morphine, just to help with that feeling of breathlessness. And like I was saying, also this anxiety component is to pair your morphine or opiate with a benzodiazepine, so maybe midazolam, just to help to calm the child through these periods and help them with that feeling of anxiety with shortness of breath.
Yeah, the gold standard being opioid and or maybe some benzodiazepine.
Yeah.
I know that dyspnea can be extremely difficult to treat in some circumstances, so it's good to have lots of different tools that one can try. Another symptom that I think can be pretty tricky to treat sometimes is nausea. And I know that nausea can come from a lot of different underlying causes. So I'm curious, again, like from that same sort of lens, what are some of the things that you might assess for if someone is complaining of nausea or you're seeing signs and symptoms of nausea? Like, what is some of your assessment and then maybe some of the approaches?
Assessment, again, we do have verbal and nonverbal children that we care for. And so once again, some kids will flat out just say, like, I feel sick, I'm nauseous, my tummy hurts. And then there's some things that we might see in other children or nonverbal children could be things like hypersalivating. So like lots of saliva, looking withdrawn. You'll notice that their skin in both verbal and nonverbal children will become like pale, usually kind of greenish looking. And, these kids just look off, vomiting. And so, if you're assessing that these children have nausea and they're not tolerating, say, their feeds or they're vomiting after they're eating, you're looking at things like, okay, what did you eat? Like, what have you had to eat today? Is it different than usual? Is there any like sickness in the house, or is there anyone around you that has maybe they have a GI bug? Did you just have a huge long car ride? Maybe you started on a new chemotherapy. Maybe there could be some reasons that perhaps a dietitian has increased feeds, if they're wanting more calories and perhaps the child's not tolerating and it's a change for them.
Yeah, and the one other thing that I thought of too in there is constipation.
Yes, that's a big one.
Yeah, and have they pooped, and have they pooped well, and have they pooped frequently?
Yes,
is a big consideration because obviously that can contribute. We know that there's lots of different underlying reasons for nausea, like chemoreceptor from taking certain medications. There can be vestibular impact from the car ride that you mentioned. There can be gut-related of feed intolerances or constipation. So there's lots of different factors, but what are maybe some of the approaches that you might take to try and help reduce, mitigate, improve nausea?
This could take a while because it depends actually like what is the cause, as you were saying, of the nausea. But if if it's the chemotherapy or a medication, then perhaps you need to be having another medication on board, an antiemetic, to help with that nausea because, those medications, some of them we can't stop. And so we just try to manage the symptoms that they impose on the child. And then constipation, huge one. So yeah, perhaps getting those bowels to move. So regular bowel care, suppositories when needed, things like that to get the bowels moving. For say feed intolerances, we look at, overall TFI for the day and like caloric intake. And a lot of our kids do better with a lower TFI than, a child that's running around and doing their thing. It just helps with their guts just to have things run smoothly. Sometimes we do things like lowering feed rates. If these kids are on enteral feeds, we'll lower their rates. Sometimes we reduce the concentrations of their feeds. And then, based on what's causing, if it's the vestibular thing, we could maybe be looking at some Gravol as well. Yeah, it really depends on what the cause is of the nausea.
I think depending on reasons for the nausea again, but I also think about some of these kids that do better with clear fluids for a day, or if they're oral eating, maybe just bites of popsicles, things that are really easy to digest. So like I hear you talk about making adjustments to feeds, and then smells. I know for some kids the smells are also can be stimulating for nausea as well as helpful. That some of the kids that enjoy the smell of peppermint can be soothing, but the smell of mom cooking dinner can trigger off even more nausea. So considering that scan of their environment as well in terms of what are some of the smells that might be triggering for them, or what are the tastes that might help or make things a little bit worse for them.
For sure. Again, like open that window, get some fresh air in, right? And try to change the scenery that they're into, and then reassessing, like, are these interventions working? Is that smell that maybe you or I feel like it would comfort us for nausea making theirs worse, or that medication, is it helping? Should we think of something else? And then again, like you had mentioned before about positioning is always a good one too for kids who are being tube fed in particular, having them sitting up a bit higher than usual maybe could be beneficial to them.
Yeah, for sure. So to wrap things up, I'm curious if you have any sort of pearls for maybe someone that's new or coming into or is interested in pediatric palliative care specifically. Do you have any kind of words of advice or pearls of things to consider, why they should come into pediatric palliative care, like someone's that is considering it as a new shift in their focus, for example?
I think if you're considering it, do it, because it is amazing work. Some people say to me, you know, how do you do that job? I could never do that type of job, but it's an honor, you know, to be supporting these families in these journeys, and just, you know, getting to know these families and these kids. It's incredible. And I think because it is so new in, you know, the medical world of research and all of the things, it's always just know that you don't know everything, and always keep asking questions and reading research and wanting to learn. And if relationship building and pediatrics and all the fun stuff that goes involved with peds, you know, really strikes you as something that you'd be interested in, just try it out. It's great.
I love the comment about the fun too, because I think that a lot of people think our job is really depressing. And yeah, for sure there are hard parts, but maybe to finish off, can you share with us a little bit about some of those fun things as part of this job? Because I think that there is laughter and there is joy, and there are a lot of really good things that we get to do in this job, and it maybe counteracts a little bit of the hard stuff.
Mm-hmm. Our job is very fun. I just spent the morning cuddling the cutest baby in my office, and that brought me so much joy, as it did to bring her joy as I saw her falling asleep in my lap. But I'm thinking of a time when we had this little girl in, and, you know, we got to know her for many, many years before she reached the end of her life, and she was with us for that. And, you know, she was very, very sick, but we, you know, in getting to know her, we knew that she loved music, and she loved to sing, and she loved to dance. And there was a point, you know, where she wasn't able to get up and dance, and so she was just weak, and she was, you know, agitated one day, and she had such a big sense of humor. And so part of my job that day was, you know, I just put on her favorite song in her room that I knew she loved so much, because she at one point was singing it at the top of her lungs so the whole house could hear. And I just jumped on a chair in her room, and, you know, I did a little dance party for her, and I grabbed her arms and, you know, her hands, and we had a little dance party. And, you know, the smile that brought to her face that day was incredible, and that was like a memory I'll treasure forever, for sure.
I love that. And the child's brain, similar to the comments around how distraction can be so helpful for pain management, a child's ability to go into imagination land and to go into play, like, that's so paramount to how well a child lives. And if a child isn't playing, we should be more worried about them, right?
Yes.
And I love that that's part of our job, to make sure that these children also get to play.
Yes, that's normalcy for them, you know, child playing. And like you said, if they're not playing, what's going on? Yeah, we can do better.
Thanks so much for spending time with us, giving us your perspective as an experienced and expert nurse in pediatric palliative care. I'm sure there's a lot of people who can learn from this, so thank you very much.
My pleasure.
Thank you for listening to this episode of the Sunflower Palliative Care Podcast. These podcasts grew from a seed of an idea as we talked with our colleagues in the Sunflower Children's Network. The Sunflower Children's Network is an initiative of Two Worlds Cancer Collaboration, which focuses on children's palliative care. We hope to build a world where no child suffers from serious health-related issues. To learn more or to donate, please visit twoworldscancer.ca.